start the class. And today's session will be about neonatal resuscitation. Okay, so this is again one of the most important topic when it comes to pediatrics. As we all know, if it comes to your theory exam during UG days, it can be asked as both your 5 marker as well as 10 marker. Coming to your MCQs, there will be invariably 1 or 2 questions from NRP most of the times. So have tried to cover, and when it comes to pediatrics as such, this is bread and butter for all of us, as we know. So I've tried to cover all the theory and all the MCQ parts as much as possible. Again, when it comes to practical aspect, and as far as we get hands-on training and a good proper NRP certification, it is difficult to tell practically how it can be done or practically demonstrated, but have tried to include few case scenarios to try and make it interesting. So yeah, I hope we can start with the class. Now, coming to the topic as such, how we'll be dealing with this, we'll know the introduction, then some amount of physiology. Okay, how do we prepare for resuscitation? Algorithm we'll have a look at, initial steps of resuscitation we'll look at. Okay, then we'll go see what are the steps like positive pressure ventilation, alternate airway, when do we give chest compression, and what are the medications that are there. Okay, so firstly, coming to the introduction. Here we'll read what is the need for this neonatal resuscitation. Correct, what is the need? So firstly, as we all know, as soon as a baby is born, there is a transition occurring, right? There is a transition occurring wherein the placental respiration, wherein initially the baby inside the mother's womb, the fetus, most of it, the blood supply comes from the placenta. So it is basically the placental respiration that is responsible. But as soon as the baby is born, a rapid transition has to be made from this placental respiration to neonatal respiration involving the lungs, correct? So whenever there is some abnormality in this transition, that is where the need for this resuscitation comes up. And because of this need for resuscitation, our NRP, that is the Neonatal Resuscitation Program, has come up with the guidelines as to how to go about this resuscitation, correct? And coming to some amount of history, the first formal guideline as to how it is done came up long back in 1987. Okay, following this, there have been regular updates, and there have been 8 such updates. There have been 8 such editions of the NRP book, and presently the 8th edition of NRP is present. Okay, and it was released in 2021. Okay, now next, let's see who forms this, what is the institution that comes up with this guidelines. Okay, so based on the recommendation given by ILCOR. Okay, ILCOR is nothing but International Liaison Committee of Resuscitation. Okay, based on the recommendations given by this committee, they are doing continuous research and they are giving consensus guidelines. Okay, and based on the recommendations given by them, the American Heart Association, okay, and the American Academy of Pediatrics together sit and come up with the guidelines. Okay, and this guidelines comes up with its updates and new recommendation every fifth yearly. Okay, now let us look into some of the statistics. What is the significance of this? Well, most of the babies, as soon as they come out of mother's womb, they make a successful transition. They do breathe in air and they make a successful transition. Then why does this resuscitation come into picture? Of the 100 babies born, okay, sorry, I just got disconnected. Okay, I just got disconnected. I hope I'm audible now. Okay, so am I audible? Is everything fine? Could you please tell in the chat section? Yeah, okay. So of the 100 babies that are born, approximately around 5 to 10% of the babies, okay, 5 to 10% of the babies might need suction and stimulation, tactile suction and stimulation, which is the first initial step of basic or resuscitation, and around 3 to 6% of them, around 3 to 6 babies of the 100 babies might go ahead and need bag and mask ventilation, which is the positive pressure ventilation required. And those two account to basic NRP. And going further ahead, of the 1,000 babies, around very less, around 1 to 3 might need advanced NRP. That is an alternate airway like endotracheal intubation. Okay, so it has had a very significant amount of effect in reducing the neonatal mortality rate, as well as reducing the amount of birth asphyxia babies which might go ahead and become a case of cerebral palsy, correct? So that amount of morbidity as well, it has avoided when the NRP has come into picture and has been followed in the past 30 years. So this is the significance of NRP. Okay. Now, next question, coming to the next question, what is the difference? What is the difference we are going to have between, like, there is already guidelines existing for the pediatric age group, there is already guidelines existing for the adult age group, correct? Then what is the need? What is the new need for this neonates to have resuscitation? What is the new need for the new guidelines, correct? Because when it comes to the pediatric age group or the adult age group, the problem is different. Over there is compromise in the circulation, correct? But over here, so the approach becomes different over there. First, take care of the circulation, then comes the airway, then comes the breathing. But when it comes to neonates, the problem is with the lungs, basically. There is abnormal transition, correct? So it is the respiration that is being affected, correct? So the whole focus is effective ventilation of the baby's lungs. So the main focus of this full NRP will be effective ventilation of the baby's lung. After that comes the circulation, correct? That is why the approach to the algorithm itself becomes different. So first is the airway, then comes the breathing, then comes the circulation. Okay. Hope you guys have understood the importance and what is the difference. Okay. Next, let's look into the physiology, some amount of physiology. So again, as we already discussed about this, in the fetal circulation, it is the placenta that is responsible to come and give the oxygenated blood to the fetus, correct? That is the reason why in the fetus, the lungs is fluid filled, correct? But as soon as the baby is born, this transition has to be made, and this fluid filled lungs have to be filled with air, correct? That is what happens over here. And this is the transition that is needed, correct? The fluid filled lungs should be pumped in with air, and the heart as well should pump blood, correct? So that it will get oxygenated and come back, correct? So this is the transition that has to be made from the fetal circulation to the neonatal circulation. But in case of abnormal transition, if this doesn't take place due to certain amount of some antepartum risk factors would have been there, or any intrapartum risk factors would have been there, in that case, what happens? Our usual body copes up with the disturbance that is present, correct? So it tries to arterioles in the intestines, in the kidney, in the muscles and skin, tries to constrict so that it can provide blood to the heart as well as the brain. When this happens, we get the clinical features. So what are the signs and symptoms in a neonate who has had abnormal transition? When it comes to the fetus, if we are going to know that the fetus is in some amount of distress, there is some amount of respiratory compromise that is taking place. How do we get to know? Either there is decrease in the activity of the fetus, or there is loss of heart rate variability, what we see in our NST, or there might be early or late deacceleration. So these are few of the features. When it comes to neonates, how do we get to know? The baby might be gasping for air. Gasping indicates that there is severe respiratory compromise, correct? So gasping indicates there is severe respiratory compromise. Okay, severe. Then there can be apnea. Then there can be bradycardia or tachycardia, or there can be decrease in the tone, or the baby might appear limp. Okay, or the baby will be pale, or baby will be fully cyanosed. Okay, so these are the features which we'll look for. Next, if this fetus is born in the early phase of this respiratory failure, there is some amount of respiratory compromise, and it is born in the early phase, okay, early phase of this respiratory failure, then what happens is there will be primary apnea, and the baby just recovers by some amount of tactile stimulation is good enough for the baby to recover. What happens if it is in the secondary apnea? That is, baby is in late phase of respiratory failure. Okay, this indicates that there is late phase of respiratory failure. That is when the secondary apnea comes into picture, and that is when further steps of assisted ventilation is needed. Okay, so based on this physiology, our Nrp flow diagram has been formulated. Okay, and it consists of 5 blocks of diamond and 5 blocks of rectangles. 5 blocks of diamond indicates how do we assess the baby, and rectangle shows what are the actions that need to be taken. And our basic approach, as already discussed, is temperature followed by airway, followed by breathing, followed by circulation, followed by drugs. Okay, so that is it for the physiology part. Next, let's see how do we prepare for this resuscitation. Correct? How do we prepare for this resuscitation? So even before we anticipate, first we'll have to form a team. Correct? First we'll have to form a team for this resuscitation. Then we'll have to brief each of the participants as to what are their roles. Okay, and everyone has to be a thorough NRP. They should have an NRP certificate and they need to be trained. So a trained personnel should attend every delivery. Okay. Next is, when do we anticipate that the baby might have some amount of respiratory compromise and they might get further need for neonatal resuscitation. So we'll have to anticipate, right? For that, certain risk factors do exist. So this risk factor can be both antepartum risk factors or some amount of intrapartum risk factors. This you guys can go through the table. There is a list of risk factors that is present. Okay, you guys can later go through this. Okay, next, what are the 4 basic pre-birth questions? Now you guys are ready. You have formed a team, you have assigned a role to yourself, and the obstetricians have called you. Correct? Next, what is the questions you are going to ask the obstetrician? Correct? These are the 4 basic questions. Okay, so the first question you ask is, what is the gestational age? Because the way we approach a term baby will be different from the way we approach a preterm baby. So first important question is, what is the gestational age? Next comes, what is the amniotic fluid, whether it is clear or not, whether is there some amount of meconium staining. Correct? That is when you ask the next question, whether the amniotic fluid is clear or not. Next comes whether any additional risk factors are present. So that, what are the risk factors? These are the additional risk factors. So that if there are any risk factors present, then we can anticipate that the baby might need some neonatal resuscitation is needed. Correct? Next, final question is we'll have to plan for the umbilical cord management. What is the plan? That is, whether delayed cord clamping can be done or not. Okay, and as per recommendation, delayed cord clamping needs to be done for all the uncomplicated term and preterm babies. Okay, if it is WHO recommends 60 seconds. Okay, so 60 seconds, and ACOG recommends 30 to 60 seconds. Okay, this is delayed is born. If the baby is an uncomplicated delivery, there is no need for neonatal resuscitation, then we'll have to go ahead and do delayed cord clamping. What are certain advantages of it? If when it comes to term baby, delayed cord clamping can lead to higher HB, okay, increase in iron stores, and better neurodevelopmental outcome. And preterm baby, along with these positive outcomes, there are better chances of transition. There's a better transition, okay, and as the same thing, there is more HB and more RBCs. There is decreased need for transfusion in the near future, and there is decreased risk of necrotizing enterocolitis as well as intraventricular hemorrhage. Okay, and when is this not done? Either there is some need for further steps of neonatal resuscitation, or in case of some emergency such as placental abruption or bleeding placenta previa or cord avulsion, we can withhold delayed cord clamping. Okay, fine. So these were the 4 pre-birth questions. Next, what is important is, how many of us should attend the delivery? So every birth should be attained by at least one qualified person trained in basic NRP. Okay, that is for every birth. In case any of the risk factors are present, which you have seen before, in that case, At least 2 qualified personnel should be present. Okay. And these are the list of equipments. Once we enter the labor room, once the obstetrician has briefed us about the case, we'll have to go and do an equipment check, correct? So these are the list of equipments that are needed, but I'll not go through each thing in detail. You guys can read. Whatever is important for MCQ, I'll just highlight. One is a plastic wrap to prevent hypothermia, to prevent the evaporation of heat from a preterm baby. We'll have to use when the gestational age is less than 32 weeks. And the same is for a thermal mattress as well. Okay. Next, the suction catheter size should be either 10 French or 12 French. Okay. And the pressure that needs to be set in for the suction to work should be 80 to 100 mm Hg. Okay. Fine. Next, the flow meter which we set in for the oxygen to flow should be put at 10 liters per minute. Okay. Any other important questions that can be asked? Yeah, that's it, I think. So next, other things we will see it in the as and when we go through. Okay. Now this is the latest algorithm. This is the 2021 upgraded algorithm which is there, and we have broken it into different parts. Okay. So as and when we see each part of it, we'll go through. Okay. So next, let's proceed. Okay. Let's proceed to the initial steps of resuscitation. Okay. Any doubts till now? Any doubts so far? Okay, fine. So let's look into on YouTube. Okay, fine. There's no doubt so far. So let's go ahead. Let's look into certain case scenarios. Okay. Now I think so you guys can be interactive through your chat. Please do answer. The first case scenario is of a 25-year-old healthy woman at 38 weeks period of gestation came to labor room in active labor. Okay. Her membranes rupture shortly after arrival and amniotic fluid is clear. And there are no other additional risk factors. So all the 4 pre-birth questions that you need, you are aware of now. So now the baby is born. Okay. The baby is born. Okay. So what are the 3 things you look at in the baby? What are the first 3 things you look at in the baby? Anyone would like to answer? Yeah, no. What are the 3 things you look at, Komal? Yes, first one is whether the baby is term or not. Okay. Next is the tone of the baby. And next is whether the baby is crying or it is having spontaneous breathing efforts, or whether it is having spontaneous breathing efforts. Okay. It is not just the cry. Even if the baby is breathing, it is well and good. Okay. Whether the baby is breathing or not. So these are the 3 basic questions. So this baby is a term baby with well flexed tone, and the baby is crying. So now what do we do? What do we do next? So first we see whether the baby is term, next the tone of the baby, and next whether the baby is breathing or crying. If the answer to all these 3 questions is yes, then we term the baby as vigorous newborn. Okay. And we go ahead and give routine newborn care. We put the baby immediately on mother, skin to skin contact is done, and initial steps like providing warmth, positioning head and neck, clearing secretions if anything is present, and drying the baby. These are done. And we put the baby immediately onto the mother's breast. Correct. So this was about the first case scenario. Next case, it is the same above clinical scenario, but the gestational age of the baby is 36 weeks. Correct. So now what changes? Baby is born. Okay. But now it is a preterm baby. Preterm baby with good tone and good cry. Now what do we do? Anyone? Anyone would like to answer now? The only difference now is, since the baby is preterm and since maintaining temperature is of the foremost importance, it is TABC. since the preterms have more tendency to lose heat over here, since it is this same initial steps of newborn, we take the baby to a radiant warmer which is preheated. Okay, we take the baby to a radiant warmer and we keep the baby under the radiant warmer. After this initial steps of newborn care is given, we immediately put back the baby into the mother's breast and skin to skin contact is done. Okay, so that is the difference between a vigorous term baby and a preterm baby which has good tone and it is crying well. Okay, now let's look into the next case scenario. This is of a 28-year-old mother, okay, who's referred from a peripheral setup in view of grade 1 meconium staining amniotic fluid, okay, at 39 weeks period of gestation. NST done shows it is non-reassuring, okay, hence the case is taken for section, hence the mother is taken for cesarean section. Okay, now the baby is born. Okay, now the baby is born. We know that one of the amniotic fluid is not clear, it is already meconium stained, so one of the risk factor is already present. It is a term baby, it is limp, and no spontaneous efforts is there. No spontaneous efforts is there. Now what do we do? What do we do now? Anyone would like to answer? What do we do now? Anyone? Yes, so we'll go ahead now. Since it is a no to any one of the following. Since the baby is not active and the baby is not crying, we term the baby as a non-vigorous newborn. Okay, non-vigorous newborn. And then we go and provide initial steps of neonatal resuscitation. So what are these initial steps? First and foremost is TABC. Temperature should be maintained, correct? So we provide warmth, correct? Place the baby immediately under a radiant warmer. Okay, so this radiant warmer, it should be preheated 20 minutes before the delivery. It has to be put in a manual mode, okay, with maximum temperature. Okay, maximum temperature in manual mode, preheated before 20 minutes. Okay, next is we dry the baby, okay, to prevent evaporative heat loss. And as we've already seen, if it is less than 32 weeks, we don't have to wipe the baby. Even before wiping the baby, directly wrap the baby immediately into the plastic wrap to prevent the evaporative heat loss. Okay, fine. Next is provide warmth, dry the baby. Next, stimulate the baby. According to the recent NRP protocol, it is not suction and stimulation. First, we stimulate the baby and then suction it. Okay, so gently rub the baby's back, trunk, or just flicker the extremities of the baby. Okay, then we position the airway. Okay, we position the airway in such a way that head versus neck is slightly extended. Okay, it shouldn't be too much extended. If needed for help, a shoulder roll as well can be put over here. Okay, a slightly extended neck, which is nothing but called as the sniffing the morning air position. Okay, so we position the airway in that way, and finally clear the secretions. Okay, clear the secretions. First, we clear the secretion from the mouth. Okay, and then the nose. Why do we do this? Anyone? Why do we clear the secretion from the mouth followed by the nose? Anyone would like to answer in the chat? Yes, very good. It is to prevent the aspiration of the secretion. Okay, to ensure that there is nothing left to aspirate in case the baby gasps the air. Okay, and these initial steps of resuscitation should take to a maximum of 30 seconds. Okay, so this much should be done within the initial 30 seconds. So let's go back and look at our case. Once this was done, once these initial steps of resuscitation was done, the baby recovered well. It had spontaneous efforts and heart rate was more than 100. It was around 120 beats per minute, correct? So this baby recovered well and good. So, and how do we count the heart rate? We count the number of beats until 6 seconds, okay, and then multiply it by 10. Since we cannot waste time, we just count it until 6 seconds and then multiply it by 10. Okay, now let's look into the next case scenario. Okay, this is of a 26-year-old healthy mother, okay, gravida 4, para 3, living 3. At 33 weeks period of gestation, okay, was received in hospital in active labor. No other risk factors were present, and there was no antenatal steroids given to the baby. Okay, this baby, it cried immediately after birth, okay, but had labored breathing, in the sense it had some amount of respiratory distress, and there was persistent cyanosis even at the end of 1 or 2 minutes. So what do we do to this baby? What do we do to this baby? This is a preterm baby, correct? It is a preterm baby with good tone. Cry is present, but there is labored breathing, correct? There is some amount of respiratory distress, okay? And still persistent cyanosis is present. So in this case, what do we do? Now what do we do? Should we follow any steps of resuscitation now? Is resuscitation required for this baby? Anyone would like to try now? What happens in this case? So in this case, even after we give this initial steps of resuscitation, okay, even after we give this initial steps of resuscitation, there is, the baby is fine, good, it is crying, but it has some amount of labored breathing or persistent cyanosis is there. That is the indication to give supplemental oxygen when it comes to a term baby. If it was an IDM baby which had some amount of distress, then we could have gone and given supplemental oxygen. Since now it is a preterm baby which has not received ANS and the expected complication out of it is respiratory distress, we can go ahead and give CPAP or a TPS, correct? Through TPS, we can provide CPAP, continuous positive airway pressure. So in that case, or in the labor room itself, we go ahead, position airway, okay, suction if needed. We place a pulse oximeter. Since there is persistent cyanosis, we'll have to maintain some amount of target oxygen saturation, which we'll mention later. Oxygen if needed, that is at 10 liters per minute with 30% O2 concentration, and consider CPAP if available. If available, consider CPAP. Okay. So when it comes to pulse oximeter, now let's see what are the indications for this pulse oximeter. So whenever resuscitation is anticipated beyond the initial steps of resuscitation, then we'll have to go ahead and connect pulse oximeter. Okay. Then to confirm your perception of persistent central, so if there is persistent cyanosis, there can be acrocyanosis as well, correct? So if we have to confirm that it is actually central cyanosis, then we might need pulse oximeter when supplemental oxygen is being administered, as in our present case, or when positive pressure ventilation is required. Okay. So now what is the reason behind this is to achieve this target preductal SpO2. So as it is preductal, where should we put our pulse oximeter into? To which of the 4 limbs do we put the pulse oximeter? If we have to measure preductal saturation, anyone would like to answer now? Since it is preductal saturation, we should go ahead and put the pulse oximeter into right upper limb, okay, into the right upper limb. And this is the target concentration. Again, this is again one of the most important MCQ questions. So at the end of 1 minute, what should be the saturation target? At the end of 2 minutes, what should be the target saturation? So please be aware of the preductal saturation that is needed, okay? And if in case this free flow oxygen is required, what are the devices that provide? What are the devices that provide this? You can directly put the oxygen tubing and keep it near the baby's nose to provide this free flow oxygen, or through a simple oxygen mask, or through a flow inflating bag and mask that is available with the anesthetist, or through a TPS resuscitator and a mask if it is available in the labor room, okay? So these are the free flow oxygen delivering devices that are available to provide oxygen. Okay, so we are done with the initial steps of resuscitation. Any doubt until now? Because we'll move ahead, we'll go to the next step now. Okay, any doubts until now? We can't be in case of meconium stained liquor, again, if the same criteria is satisfied, then it is a vigorous term newborn. If it is not satisfied, it becomes non-vigorous, and we carry out with the normal routine initial steps of resuscitation. There is no change. Okay. So, okay, fine. Those were the doubts. Now let's go ahead. Next comes the positive pressure ventilation. Next step in our, after finishing this initial steps of resuscitation, we have assessed the newborn. Okay, next, let's see the next step. So before that, we look into the case scenario. This is of a 28-year-old mother, okay, at 35 weeks period of gestation, okay, whose antenatal scans show that there is IUGR, intrauterine growth restriction. Fetal heart rate monitoring shows there is late deacceleration. Okay, so baby is taken up for section, mother is taken up for section. Okay, so once the baby is born, okay, it is a preterm baby. The baby appears limp and there is no spontaneous efforts. And we have gone ahead and given initial steps of resuscitation. And after giving this initial steps of resuscitation, this must take 30 seconds. Okay, then we have again assessed the baby. Okay, over here still there is no breathing. Still the baby is not breathing and heart rate is 62 beats per minute. Now what next? What do we do next? What is the next step we do? You guys have already seen the algorithm, no? So what is the next step? How do we proceed in this case? No. Chest compression comes much later. Yes, good. Now we proceed with positive pressure ventilation. Positive pressure ventilation. Okay. So this is the algorithm. This is the algorithm, and we'll see how to approach this algorithm. Okay. So if the baby is still apneic, or if the baby is gasping for air, or if the heart rate is less than 100 beats per minute, we go ahead and give positive pressure ventilation. Okay. So what are the indications for this positive pressure ventilation? One is apnea. Second is if the baby is gasping for air, heart rate is less than 100 beats per minute, and O2 saturation is below the target range despite giving free flow oxygen. Okay, so these are the indications for positive pressure ventilation. What are the devices? One is the self-inflating bag. This is nothing but the bag and mask ventilation which we do, the preterm ambu and the ambu which we have, term ambu bag which we have. If it is not connected, if there is no source of oxygen available, then we can connect it to a self-inflating bag as we see over here. Okay, if there is oxygen flow, free flow oxygen available, then we can directly connect it into the free flow oxygen. Okay, and other devices which can be used is flow inflating bag and a TPS resuscitator. Okay, so how does this work? How does this, since we mostly end up using bag and mask ventilation, how does this work? So how do we give ventilation rate at 40 to 60 beats per minute? It is based on how often we squeeze the bag. Okay, then how do we ensure that the lungs are inflating? Some amount of inspiratory pressure is going, which is determined by the peak inspiratory pressure, is by how hard we squeeze this ambu bag. Next is the peak expiratory pressure. How do we ensure that PEEP is going to being given? That is by, in case an additional valve, if it is available over here, we can adjust the PEEP that is being given to 5 centimeter H2O. And then we have a pop-off valve as well. This is a rescue valve. When the pressure is reaching 32 centimeter, 40 centimeter of H2O, it just pops off to prevent complications such as pneumothorax from occurring. Okay, so this is the preterm ambu bag which you are seeing, and this is the other device called as the TPS resuscitator. Okay, this is the TPS resuscitator which is capable of giving CPAP. Okay, fine. Next is the method. How do we go ahead and give this positive pressure ventilation? That is, first is clear secretion. Clear, and if there is any secretion present, that itself will go and block the airway. So clear the secretion. Then position the baby's head and neck. As we've already seen, some amount of extension is needed. It is called as a sniffing dog position. And then choose a proper size mask. It can either be a round mask or the anatomical mask. It can either be the round mask or this triangular mask. Whichever you choose, it has to be a proper size mask and it has to fit in properly. How do we fit in? First, you put the mask as we see over here, put it at the level of chin. Okay, then you slowly cover it into the nose, correct? So mask to rest on chin, cover the mouth and nose, but it should not cover the eyes, but it should not be covering the eyes as we see over here. Initially put it over the chin, then cover the whole face, cover the nose. Okay, but make sure that the eyes are not covered. Okay, so what is the technique? We can either make it using the one hand technique, using just the one hand, so that you hold the mask using the C technique, as it is seen in picture. Okay, and then you give some amount of thrust over the jaw using the E technique, these 3 fingers over the jaw, correct? This is the E and this is the C. This is the C, this is the E, correct? This is the technique. The same thing, if there are more than more than one person available, then we can do using the two-hand technique with jaw thrust, okay? So it is as simple as that. Next is the oxygen concentration. Next is the oxygen concentration. What is the amount of concentration? If it is more than 35 weeks period of gestation, then we give it at 21% O2. Okay, that's it. At room air itself, we can give. If it is less than 35 weeks period of gestation, then we titrate the oxygen between 21 to 30% O2. Okay, and both the things, the flow, the rate of flow will be 10 liters of O2 itself. Okay. Next, what is the rate at which this positive pressure ventilation has to be given? That is nothing but 40 to 60 beats per minute. Okay, now how do we know it is going at 40 to 60 beats per minute? That is when we'll have to know the rhythm. That is nothing but we will go as breathe 2, 3, breathe 2, 3, breathe 2, 3, breathe 2, 3. So that is what you'll have to keep telling in your mouth. And when each time you tell breathe 2, 3, when you tell breathe, you give the positive pressure ventilation. For 2, 3, you wait. Again, when you tell breathe, give the positive pressure ventilation. So that is the rhythm that needs to be maintained. If you are able to set the PEEP, if you have that facility in your ambu bag, then you set it at 5 centimeter O2. Peak inspiratory pressure, if you will have to set, if you're using a T-piece, then you can set the PEEP as well. That is at 20 to 25 centimeter H2O. Okay, in term babies, we can go up to 30 to 40 centimeter H2O as well. Okay, fine. This is how we give positive pressure ventilation. So now let's come back to our case. So we have given good positive pressure ventilation. So one of the scenario arrives that the baby begins to cry and heart rate is more than 60 beats per minute. So, okay, fine. We have given positive pressure ventilation, okay, for 15 seconds. That is when we need to do our first assessment. So we go ahead and check heart rate of the baby. Okay, so in our case scenario, there is heart rate is increasing. Now what do? We continue positive pressure ventilation for another 15 seconds, okay, and do a second assessment, okay. So here we make two assessments. One is at 15 seconds, okay, and see whether heart rate is increasing. If positive pressure ventilation, then if it is increasing, you continue the positive pressure ventilation and do second assessment at the end of 15 seconds. If heart rate is not increasing, then what do? We go ahead and see whether there is effective positive pressure ventilation is being given or not. And how do we determine this effectiveness is by looking at the chest, correct? If there is good amount of chest rise, if there is ample amount of chest rise, that is if the chest is moving with each positive pressure ventilation you give, that means the positive pressure ventilation you're giving is effective. So we'll have to continue the positive pressure ventilation for another 15 seconds because a total duration of effective positive pressure ventilation should be 30 seconds. Okay, and make our second assessment. If it is not moving, that means we are going wrong somewhere, correct? We are going wrong somewhere. Effective positive pressure ventilation is not being given. So we'll have to take certain corrective steps. That is what we call it as ventilation corrective steps. Okay. Let's see how do we give this ventilation corrective steps. This is easily remembered by this mnemonic called as MR SOPA, correct? MR SOPA. This is the mnemonic which we use. So now the case scenario arrives that the baby which did not cry, you've given the positive pressure ventilation. Okay, you've gone ahead, given the positive pressure ventilation. Okay, but the chest is not moving. That is when you take the ventilation corrective steps. Okay, so first one is M. You adjust the mask. You look whether the size of the mask is adequate or not, and make that if there is some misposition of the mask, you adjust it. Okay. Next, you reposition the airway. You make sure that the head and neck is aligned, jaw thrust is given, the tongue is not falling back. So you reposition the airway. Okay. Next, after doing this, you again continue with the positive pressure ventilation. If the chest is moving, then well and good, continue positive pressure ventilation for 30 seconds. If there is no chest rise, then again come back and suction the mouth and nose, because there might be some amount of secretions that is blocking the airway and not letting the chest to move. Correct? Then open mouth, open the mouth and lift the jaw forward so that the tongue is not fallen back. So after doing these two steps, again go ahead and give positive pressure ventilation. Now if the chest is moving, again continue with the 30 seconds of bag and mask, 30 seconds of bag and mask. If still it is not moving, next step is to increase the pressure. Increase the pressure in increments of 5 to 10. In a term baby, we can go up to 40 centimeter of H2O. In a preterm baby, maximum pressure that can be given is 30 centimeter H2O. Now again repeat the same, try to give, still if the chest is not moving, then we'll have to consider alternate airway. So that is the next topic and we'll deal with it later. So by the end of 30 seconds, if there is effective positive pressure ventilation, by the end of 30 seconds of effective positive pressure ventilation is when we make a second assessment. First one is after 15 seconds. Second one is at the end of 30 seconds of effective positive pressure ventilation. By effective, we mean that there is chest rise. Okay. So now we'll look at the second assessment. Again, we'll get back and check our heart rate. If our heart rate is more than 100 beats per minute, we continue positive pressure ventilation at 40 to 60 cycles per minute until the spontaneous efforts come back. Okay. If it is between 60 to 90 beats per minute, again, we'll have to get back and reassess our ventilation and get to ventilation corrective steps. If it is less than 60 beats per minute and ventilation corrective steps have been taken, then we'll have to consider alternate airway. Okay. So next we'll be dealing with the next step of resuscitation, that is alternate airway. Until here, you guys have any doubts? Any doubts? So if a neonate is delivered but did not cry after birth, immediately heart rate is 46. Again, we'll have to follow the same neonatal protocol what we have followed. If you do your initial steps of resuscitation, then do positive pressure ventilation. Still, if it doesn't respond, consider alternate airway. I hope your doubt is clear, Rahul. On Zoom, any doubts? Okay, fine. So then let us go ahead. Okay. Now we'll come to alternate airway. So that brings us to our next case. Okay, This was of a 35-year-old lady. Okay, 35-year-old mother with MSAF. Okay, with NST showing fetal bradycardia. Okay, so due to this reason, mother was taken up for section since she was not in active labor. Okay, she was taken up for section. Next, baby did not cry, it was limp. Okay, but it was a term baby. Since it was a non-vigorous baby, initial steps of resuscitation was tried, but heart rate was around 40 beats per minute. So effective positive pressure ventilation was again tried. Still the heart rate was less than 60 beats per minute. Now what do we do? Okay, now I can actually give two case scenarios. Okay, the same baby, after receiving 30 seconds of effective positive pressure ventilation, heart rate had increased. Okay, heart rate had increased to 110 beats per minute. Okay, so you continued the positive pressure ventilation. But even after giving positive pressure ventilation for around 2 minutes, respiratory efforts did not come back. There was no spontaneous efforts. Okay, no spontaneous efforts. This is one of the case scenario. Next case scenario was even after giving effective positive pressure ventilation, heart rate was still 25 beats per minute. So how do we proceed in these two case scenarios? This is the first case scenario. This is the second case scenario. Okay, one of the doubt, after second positive pressure ventilation, after 15 seconds, if heart rate is increasing, what to do? So that only you continue positive pressure ventilation until spontaneous efforts come back, Komal. Okay, I hope you understood. Anyone want to answer now? What do we do in the first case? What do we do in the second case? Anyone? Anyone would like to answer? Okay, fine. It might be confusing. Yeah, both the cases we will have to consider alternate airway, that is endotracheal intubation or laryngeal mask airway. After putting the alternate airway, what do you do? How do you proceed next in case 1 and case 2? What do we do over here? What do we do over here? Over here, since the heart rate, okay, fine, we'll see the full thing, you will get to know. Okay, so how do we go ahead and give this alternate airway? If there is a trained personnel in advanced NRP, then we can go ahead and put an endotracheal tube intubation. If not, consider laryngeal mask airway. Okay, so what is the indication for this alternate airway? One is positive pressure ventilation with the face mask, okay, and does not result in clinical improvement. This is effective positive pressure ventilation, or positive pressure ventilation that lasts for a few minutes. So this was our first case scenario. This was a second case scenario. There was positive pressure ventilation. It lasted for a few minutes, but still there was no spontaneous efforts. And there was no clinical improvement at all, correct? So how do we deal with such cases? And strong recommendations is given whenever chest compressions become necessary and certain special circumstances like a case of congenital diaphragmatic hernia, or if it is a very preterm baby around 28 to 29 weeks, there is significant amount of respiratory distress. And anyhow, you're going to administer surfactant. In that case, you can go ahead and intubate, or direct tracheal suctioning is needed. Like you are giving positive pressure ventilation for a MSAF baby, but there are some amount of meconium flux that is obstructing the airway, and you'll have to clear the trachea by suctioning, then intubation is indicated. Okay. Next is, this is one of the important MCQ. The following two sections. One is, what is the size of the blade? If it is term newborn, we use 0.1. If it is preterm newborn, we use 0. And if it is a very preterm newborn, we use 0.0. It is a straight blade named by Miller. So it is the Miller's blade. Okay. Coming to the ET size, it is 2.5, 3 and 3.5 size. When do we use each of this? If the gestational age is less than 28 weeks and weight of the baby is less than 1000 grams, we use a 2.5 size AT tube. If the weight is between 1000 to 2000 grams and gestational age between 28 to 34 weeks, then we use a 3 size AT tube. And if the baby is more than 2000 grams and more than 34 weeks, we go ahead and use a 3.5 size AT tube. So these two make up important MCQ. Okay, fine. Please do remember. Next, how do we position? Head should be in the midline. Neck should be slightly extended. You can take the help of shoulder roll if you want. And the body should be straight. And the maximum time that can be given for intubation is 30 seconds. Okay, so if you are not able to secure in 30 seconds, we'll have to go ahead with laryngeal mask airway. Okay, fine. So that is why the need of an advanced NRP trained personnel comes in. Okay. Then we'll have to start ECG monitoring. That is the recent NRP guidelines that says that you start the ECG monitoring as soon as alternate airway becomes necessary, and to decompress stomach and make sure that whatever positive pressure ventilation you're giving, the diaphragm doesn't come up and again compromise the respiration. We'll have to put an NGT tube as well, nasogastric tube, to decompress the stomach. Okay. So after doing this, we intubate the child. So how much deep do we go? That is determined by the nasotracheal length. Okay. So we measure from the middle of the baby's nasal septum to the tragus. Okay. And then we add 1 centimeter to that. So that is the depth to which we insert the ET tube. Okay. Then after inserting, how do we confirm that the ET tube is inside the trachea? How do we confirm? Anyone would like to answer this question? Now you have made sure you have intubated the child. Now, how do you confirm that it is inside the trachea? Okay, good. One is by auscultation. Any other method? Bilateral air entry should be equal. Where do we auscultate? To make sure that there is bilateral air entry equal. Second, you look for chest rise. Good. But where do we auscultate? Should we auscultate over the chest, over the back, over the axilla? Where? At xiphisternum. No. Then how do you know if you measure at xiphisternum bilateral air entry is equal or not, Ritu? Yes, good. We look at the axilla. Okay, fine. So if you have an endotracheal tube CO2 detector, EtCO2, then okay, fine. If it is not available, audible and equal breath sounds near bilateral axilla. Okay, symmetrical chest movement, symmetrical chest rise should be there. Little or no air leak from the mouth should be present. Okay, and there should be no, or there should be very less air entry over the stomach, indicating that there is no air leak. If these are the few above indicators are present, that means whatever positive pressure ventilation you're going to give henceforth is going to be effective. Okay, so now let's come back to the case scenario before. If the heart rate is more than 100 beats per minute, more than 60 beats per minute, as was with our case scenario 1, in that case you continue with your positive pressure ventilation at 40 to 60 cycles per minute. Okay, so continue with positive pressure ventilation with the ET tube in situ at 40 to 60 cycles per minute. Okay, this is one. If heart rate is less than 60 beats per minute, then you start chest compression. Then you start chest compression as well. Okay, fine. So that was the logic behind the question. So next is, how do we administer this chest compression? So now we are going to next topic. Before that, any doubt? I don't see any doubts. Fine. So let's see, how do we give this chest compression? How do we give this chest compression? What is the indication for chest compression? As we've already seen, heart rate less than 60 beats per minute. After at least 30 seconds of positive pressure ventilation, 30 seconds of positive pressure ventilation, which is effective. That means, how do we determine this effectiveness? That inflates the lung, evidenced by the chest movement. Okay, evidenced by chest movement. So this is the indication for chest compression. So, and whenever chest compression is needed, we'll have to intubate the child. So what is the position? Now we need two personnel, correct? One to give the positive pressure ventilation, and one more personnel to give this chest compression. The person who's going to give chest compression stands near the head of the baby, and this person who's going to give the positive pressure ventilation will stand towards the right side of the baby. That is the position. Next is technique. How do we give this? How do we end up giving this chest compression? First is the location. Location is this is the line connecting the two nipples. Right below it, over the xiphisternum, you go ahead and give the chest compression. Okay, how do we give? You encircle the chest with your fingers, and then you make sure that the bilateral thumbs are in this position shown in the figure, and then start giving chest compression to approximately 1/3 of the anterior-posterior diameter of the chest. Correct? So this is the technique. Next is, what is the rate and rhythm? So rate is 90 chest compressions per minute. Second part is ventilation, that is 30 ventilations per minute. We need to make sure that 90 chest compressions are being given and 30 ventilations per minute is also being given. So what becomes the ratio? For every 3 compression, 1 ventilation has to be given. So, and this has to take place within 2 seconds so that this target is achieved. To know this, we'll have to know the rhythm. Rhythm, until and unless we practice, will not get it, but it is called as 1 and 2 and breathe in. 1 and 2 and breathe in, correct? So 1 and 2 and breathe in means when you do 1, 2 and 3, 1 and 2 and 3 and breathe in. When you do 1, 2 and 3 is your chest compression. When you do breathe in is when you give the positive pressure ventilation. So we go as 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in. Okay, this comes with practice. Fine. Next is, what is the oxygen concentration? As soon as we start giving chest compression, our oxygen concentration, which was 21% for term and 21 to 30% for preterm babies, should increase to automatically to 100% oxygen saturation. Okay, so now we are done. We have given effective chest compression along with positive pressure ventilation. Next, what do we do? After 60 seconds of effective positive pressure ventilation and chest compression, we reassess the heart rate. Now, if the heart rate is more than 60 beats per minute, okay, fine, good, you're successful with your neonatal resuscitation. You continue the positive pressure ventilation. If not, that is when comes the medications. Okay, that is when comes the role of medication, and that brings us to our last step of neonatal resuscitation. If heart rate is still below 60 beats per minute, we go ahead and administer IV epinephrine, adrenaline. We go ahead and administer. Now, as already told, what is the indication? Heart rate below 60 beats per minute, even after 30 seconds of positive pressure ventilation that inflates the lung, and another 60 seconds of chest compressions with positive pressure ventilation at 100% O2. If these two things have already been done, then that is the indication that we should go ahead and start giving drug. That is, epinephrine is administered. What is the concentration? 1:10,000. 1:10,000 dilution. The ampule you get is 1:1000. That you dilute it with 10 ml NS, so it becomes 1:10,000. Okay, and the concentration in it will be 0.1 mg per ml. Okay, so 1 ml will have 0.1 mg of the drug. Okay, how do we give it? Through IV route, that is after securing a UVC. Okay, this is the most preferred method. If not, intraosseous, and the least preferred of all is the endotracheal tube. Okay, through the endotracheal tube itself, we can give the drug, but this is the least preferred of all. Next, coming to the dosage. If it is IV or IO route, the dose is 0.02 mg per kg. Each dose should be 0.02 mg per kg. If it is through endotracheal route, then it is 0.1 mg per kg. Now, and we should also make sure that through the UVC, after we have given the drug, to make sure that the drug enters into the circulation, you should flush it with 3 ml of NS. Okay, so make sure that you flush it with 3 ml of NS. Okay, when to repeat the second dose? After 3 to 5 minutes. Every 3 to 5 minutes, we can repeat the second dose of epinephrine. Okay, so we have given epinephrine. We have still continuing to give positive pressure ventilation even at the end of 3 to 5 minutes. If we are not able to achieve the heart rate of above 60 beats per minute, in that condition, we might have to consider other alternative causes as well, like hypovolemia or pneumothorax. Okay, in case of hypovolemia, volume expander has to be given. Since you have already secured the UVC route, you can as well easily give, like any crystalloid can be given 0.9% NS, or if the baby is having severe anemia, you can give PRBC as well if it is already ready at 10 ml per kg. So what are the indicators? There are a huge list, like any acute fetal-maternal hemorrhage, bleeding vasa previa, extensive vaginal bleed, etc., which you can read. So these are the indicators where the baby might be in shock, and volume expander might be needed. Okay, so give 10 ml per kg as bolus. If there is no improvement, then you can as well go ahead and give one more extra 10 ml per kg bolus over 5 to 10 minutes. Another cause that can be considered is pneumothorax. Okay, how do you know pneumothorax is there? Either when you're bagging, there's no, even after you've done everything, there is no effective PPV taking place because there is unilateral more and the other one is less. One side the expansion is more, the other side expansion is less. Or when on auscultating, one side you're able to hear well, other side you're not able to hear, or there's reduced air entry. In such circumstances, you know that there is pneumothorax. In that time, you'll have to take an immediate X-ray, okay, confirm, and then you'll have to evacuate the pneumothorax. If you're going to do thoracocentesis at fourth intercostal space, then anterior axillary line is preferred. At the second intercostal space, mid-clavicular line is preferred. Okay, fine. So that was to know about the last step of our resuscitation. So how long do we continue? How long do we give in our efforts? It is an independent decision. So you can go ahead more than 20 minutes also, but we'll have to at least try for 20 minutes. That is what our NRP book says. So minimum time frame for resuscitation is 20 minutes. Okay. So I think so I've covered all the points and all the steps are also covered, I think so. One last MCQ that might be asked is, what is the ideal labor room temperature that has to be maintained? What is the ideal labor room temperature that has to be maintained? Anyone? It is 24 to 26 degrees Celsius. Yes, good. 24 to 26 degrees Celsius. Fine. Yeah, it is 8 o'clock. I think so. We can wind up. Any doubts? You guys can ask. Any doubts, guys? It is not more than 25. It is at 25. Okay, 24 to 26 degrees Celsius. Any other doubts? Okay, nothing there on YouTube as well. So, okay, fine. Anytime you guys have doubts, please, you can always contact me. Okay, this is my mail ID and my WhatsApp number. So I guess we can wind up the class. Okay, guys. Bye bye, guys. Thank you.